We'll move to the next session, which would be chaired by my friend, Dr. Barnali Das, who is a consultant in the Department of Laboratory Medicine at the Kokilaben Dhirubhai Ambani Hospital in Mumbai. So over to you, Dr. Barnali.
Thank you, Dr. Subin, for a kind introductions, and thanks Kaho and Kaho Diagnostic Division, Dr. Seema, Dr. Aparna, Dr. Subin, and Dr. Vijayagar Valsa and Dr. Lalu. And I'm honored to be part of Kaho Diagnostic Division and Kaho LABCON. Kaho is crucial to incorporate quality competence in healthcare and is working on implementation of standardization and harmonization of lab testing, bridging that gap between the diagnosticians and clinicians and even different facilities or different faculty like hematology. We have heard about immunology, hematology, transplant immunology, molecular biology. So, being executive member of International Federation of Clinical Chemistry Lab Medicine Scientific Division and chair of American Association of Clinical Chemistry India section, I congratulate Kaho and Kaho Diagnostic Divisions for such amazing symposium and such amazing webinar. And IFCC has been entrusted with the responsibility on the need of method standardization and harmonization across the globe. And IFCC encouraging a lot of awareness channels, organizing events, research publications, articles, projects. And they are discussing with lab community, clinicians, clinical societies, and also the societies like Kaho, IVD industry, regulatory bodies, and EQA providers to formulate guidelines for assisting in correct measurement, diagnosis, and management of disease. And IFCC is happy to be a knowledge partner of first Kaho LABCON 2021. So now going to our today's topic of Sigma metrics in medical testing lab, which is very important for incorporating quality competence in lab. So now the speaker of this session is Dr. Douglas Chung. He is Asia Pacific Co-Diagnostic Marketing Manager from Abbott Laboratories, Singapore. He has worked for over a decade in diagnostic field across multiple disciplines, including clinical chemistry, immunology, molecular bacteriology, and blood banking. He received his undergraduate education in molecular biology from University of Pennsylvania, and then he was did his infectious disease training from Chung Faculty of Medicine in Hong Kong, and he has earned his doctorate, research doctorate at Newcastle. His research focused on lab detection and control of drug-resistant infections and also the lab quality management. So he is passionate about community engagement. He currently serves as IFCC Congress Committee and volunteers as an admission interviewer for his alma mater. So over to you, Dr. Douglas, and now we all know there is continuous challenge in healthcare system to provide better diagnosis while incorporating quality credentials along with cost reduction. So let's hear from the expert that what laboratory strategies to incorporate for revenue generation with quality healthcare through Lean and Six Sigma.
Sure, great. Thank you very much for the kind introduction. And thank you very much to the Kaho organizers, LABCON organizers, for inviting me to speak. Coming from Abbott, it is our great pleasure and honor to support this, great event as an associate sponsor. Okay, so I'll be giving a very brief 15-minute introduction to Sigma metrics in the medical testing lab. What is Sigma? How do we calculate? How do we apply it? And really, what's the benefits? Now, what is sigma? Sigma derived, represented by the Greek letter sigma, right? It's a metric on the logarithmic scale that's used to represent the number of defects per million opportunities, and that's DPMO, right? So as you can see on the right-hand side on this table here, as your sigma metric goes up from 1 sigma to 6 sigma, your DPMO, your defects, goes down logarithmically, okay? So at 6 sigma, you are at 3.4 defects per million. And of course, sigma can go up beyond 6 to 7, 8, 9, right? You can go up to infinity sigma, but the DPMO, your defects, will approach 0 logarithmically, but never really reach 0. Now, why do we focus on 6 sigma, right? Because it is a statistical methodology that was first pioneered by Motorola in the 1980s and now widely adopted across different industries to manage and improve large-scale processes to minimize defects and achieve this world-class quality. Okay. Now, for us in healthcare and in the medical lab, we also strive to deliver world-class quality, right? That's why we're using the sigma approach, right? Because we process millions of patients every day. We process millions of test results every day. These are high volume processes. And this sigma approach can be applied to the entire testing process to monitor and control pre-analytical, analytical, and post-analytical process, and for both qualitative and quantitative tests. But for today, I'll focus on just the analytical phase and looking at just the quantitative tests in the clinical chemistry and the immunology core lab, because that's the bulk of the volume, the majority of the workload that we have in the lab medicine department. Now, how do we calculate the sigma metric? You see here, this is the equation for sigma, where you have TEA, your total allowable error, minus your absolute bias divided by the CV. You all know how to derive the bias, the CV, right? It's coming from your routine lab statistics that you do every day. It's your accuracy coming from the difference between your lab value and the reference value or the peer group value. And then your CV is your imprecision or your reproducibility. And then lastly, your TEA or your total allowable error is really what is the tolerance that's required for that particular analytes, right? Now, according to the clinical lab improvement amendments in the US, the TEA for different analytes will be different, right? So for alkaline phosphatase, it's plus or minus 30%. For chloride, it's plus or minus 5%. And that's different because of different clinical needs, right, required for that particular analyte or for that test. So based on this sigma equation, we can then flip this around, where we can have plot the bias on the y-axis and the imprecision on the CV on the x-axis, and where the sigma becomes the slope, and you have the intercept represented by the total allowable error. And you get what's called a method decision chart, right? Where you have allowable inaccuracy or your bias on your x and your imprecision on your y, and your imprecision on your x-axis. Here you see that as your accuracy increases or as your bias decreases, right, you get better and better accuracy. And as your CV also decreases, you get better and better precision. So that's why for lab performance, analytical performance, we want to be in this lower left-hand corner where you have good accuracy and good precision. And as you get away from this lower left-hand corner, then you get towards marginal and towards unacceptable performance. Now, this method decision chart can be used, and this sigma process can be used to assess the quality of different things. So first, we can use it to assess a single analytes across multiple systems. This study came from the US and was presented at IFCC in 2015, looking just at HbA1c. So you have different data points. Some were on the Roche system, some were on TOSO system, some were on BI-RAD system, some were on Abbott system, etc. Right? So as you can see, the sigma metric or the sigma approach can help in choosing the right method and help to determine if your analytical performance is suffering from bias, where you can see some of these data points here have very high bias, or whether you're suffering from high level of imprecision, or whether the issue is coming from both bias and imprecision. And of course, you can identify which are those methods that are in this lower left-hand corner that are giving you world-class quality. Second example, you can also use sigma metrics to assess multiple tests on one system across many different labs, right? So this study came out in 2018 and was published in Clinical Chemistry, looking at 11 hospitals evaluating 18 tests on one system. Okay, this is the Alinity system. And they were able to adjust that formula by pooling the bias and pooling the CV across multiple sites and deriving the sigma metric and plotting that on the method decision chart. As you can see on this particular system across multiple hospitals, they were able to achieve excellent performance with most of these assays operating in this lower left-hand corner. Third example, you can also use this process to assess multiple analytes across different systems. So Westgard did an objective apples-to-apples benchmark study with real QC data from labs around the world. And as you can see, some instruments have good performance with many points in this lower left-hand corner. Some instruments have average performance, and some instruments may have poorer performance. Okay, so not all chemistry tests are the same. Not all chemistry systems are the same. So this process can help you to identify which test to use as well as which system that you want to use. Now, why should we use sigma metrics in the medical lab, right? And that's because recent publications and guidelines include recommendations for applying sigma. You have IFCC, AACB in Australasia, as well as the CLSI in the US, and as well as multiple recent publications as well. Let's take a look at the CLSI. In 2016, the C24 new guidelines came up. This is the 4th edition. You see that for high sigma, right, they're specifying that for your high sigma assays, you can use less stringent rules, such as 1,3S or 1,4S. But for your poor assays with poor performance, such as those with 2 to 3 sigma, you need combination of QC rules. You may need to accept higher false rejection rates, and you will also have the probability of detecting an error detection that may be less than ideal. That means higher risk for the patients. And thirdly, this is a very interesting point, so please remember this, right? So you may also need to consider increasing the frequency of performing QC as well. And I put this in a different color because we'll come back to this a little bit later on. And here we come to the evolution of sigma-based QC. You may all remember the original Westgard rules, which came out just 40 years ago, just celebrated the 40th anniversary in March 1981 when this first came out by Dr. James Westgard, and recently in 2014, the Westgard Sigma rules, where Dr. Jyothi also just presented that everybody should be well aware by now, right? So what's the main difference, or what's the evolution here, right? In 2014, with the Westgard Sigma rules, you see that the 1,2S warning rule is now gone, and that we now have sigma zones. So say, for example, when you are operating at 6 sigma performance, you only need to apply the 1,3S rule, and you only need to use 2 control measurements per run, and you will be okay to go. However, if you are at 3 sigma performance, you will need to use all of these QC rules, and you will need to either measure 8 QC measurements per run, or you may need to do 2 runs and measure 4 QC measurements per run. Now you may be wondering, where is 2 sigma? Where is 1 sigma? They're not on this flowchart, right? And that's because when you are at 2 sigma, 1 sigma performance, it is actually impossible to really do enough QC, right? You can never use enough QC in order to catch those errors because you're just generating so much errors. So that's why sigma will help you to identify and choose those assays that are really operating at this higher level so that you can avoid, firstly, right, a situation where you're not using enough QC rules to control for the results. And secondly, you're avoiding a situation where you're using so much QC and using so many QC rules. Now, labs have demonstrated that there is significant improvement after implementing this process. You see, this is a recent publication or presentation in AACC showing significant cost savings because they were able to streamline and optimize their QC. Another publication from AACC in 2016 also showing a 91% reduction in the false QC rejection, many less QC rejections, much less troubleshooting, recalibrations, reruns, etc. Okay. This is the next evolution here. In 2018, the WestGuard Sigma rules was complemented with the run size calculations that WestGuard was able to integrate with the latest research. You see that now with Six Sigma, there is an official recommendation that Six Sigma assays, you can run QC every 1,000 patient samples. For 5 Sigma, for every 450 patient samples, and all the way at 3 Sigma, you need to run QC every 45 patient samples, right? So what does that mean? What's the impacts inside and outside the lab? For high quality assays, you can reduce your QC measurements per run, right? That improves your cost efficiency and your reagent consumption. You can use less QC rules. That will allow you to maintain high error detection while minimizing all of the turnaround time delays, all of the unnecessary troubleshooting, all the rework from your false QC violations. You can also improve your clinician confidence and your satisfaction because you have high quality. And that brings you reputation and revenue impacts. What about if you have poor quality, right? You need more QC measurements, you need more delays, repeats, recall results, and that will lead to financial impacts as well. CLSI, the QMS 20 report on the laboratory cost of quality, actually has a calculation in there. This is the cost of poor quality, COPQ, where at 3 Sigma, you're actually spending 24 to 40% of your lab revenue just to manage that poor quality, right? And at 6 Sigma, it's actually that impact is just less than 1% of your revenue, right? In India, we know that we have the NABL guidelines, right? So NABL is very prescriptive when it comes to which rules to use, as well as what's the frequency, right? So NABL, so I think all of you in the audience are very well familiar with the NABL requirements, right? They're not yet harmonized to the latest CLSI recommendations, but we'll see what happens in the future. And so in conclusion, I just want to conclude that Sigma metrics can first be useful tools for objectively assessing and benchmarking your performance in the lab, aiding in selecting the appropriate method and the appropriate system for you when you're deciding what to use, and also in optimizing your QC strategy via the appropriate QC rules and the appropriate QC strategy, QC frequency for each test. And secondly, we have shown that labs around the world have demonstrated their success with Sigma, right? By improving the cost and the manpower efficiency of the laboratory, by eliminating all of the unnecessary repeats, reruns, troubleshooting, all of those extra rules that they didn't need to run, while continuing to comply with guideline recommendations and accreditation requirements, ensuring the safety and minimizing the risk to patients. And lastly, thank you very much for your attention. If you would like more information, you're welcome to go on our website, get a free ebook on Six Sigma that we have invited Dr. James Westgard and Mrs. Sten Westgard to write for us, as well as reach out to our local friendly ambassadors who are more than happy to help you with more information if needed. And with that, that's the end of my presentation. I'll be happy to answer any questions.
Thank you, Dr. Douglas. Is like, one lab scenario, you think like there are multiple instruments and multiple assays, like maybe 150 different clinical chemistry assays. And because based on current guidelines, like one assay may be performing at 3 Sigma, another assay performing at 4 Sigma, and another 5 Sigma or 6 Sigma. So multiple assay, multiple instrument, different Sigma levels. And so how to, for that lab, the difficulty is like, which rule to incorporate, because one assay maybe for creatinine is at 6 Sigma level, so they have to incorporate, run in now current guidelines in thousands, but if we see an nabl and this Sigma rules, we club together. But suppose another assay like for electrolytes, some analytes, it's showing 3 Sigma level. So for a technical support team or technicians who is running, so every day based on the Sigma level, multiple analyze different Sigma and different rules and different frequencies. So how to harmonize that, or how to incorporate the Sigma when they have multiple assays on multiple instruments?
Sure, great. Thanks for that. Very interesting and very good question. So, when you're talking about, individualizing each assay on each instrument, it can become so complicated and you can get to a stage where it becomes very difficult for a frontline technician to manage so many different things at the same time or on the same day in the same lab, because there are so many other things happening, right? So in that case, we have seen that many labs are following a kind of categorization. They are splitting their analytes and their analyzers into maybe 2 or 3 different categories. They have maybe one category of high quality assays and high quality analyzers, where they can just manage maybe just 1 QC at the beginning of the day and then maybe 1 QC at the end of the day. And then they have another category, second category of maybe average quality performance assays, where maybe when afternoon shift comes in, then the afternoon shift then may need to perform an additional QC and apply those additional rules. And then you have this third category of poor performing analytes or poor performing instruments, where additional maximum QC and maximum rules may then need to be applied. So that helps to simplify things a little bit, as opposed to trying to personalize and individualize each individual analyte at each individual QC level down to that level of detail, where it becomes more difficult to manage and implement practically.
Yes, so I think high frequency analyte, medium frequency analytes, and low frequency we can decide based on the sigma level. So another question is from Dr. Archana. The total allowable error for electrolytes is very narrow. So is it possible to achieve 6 sigma?
We have seen that, yes, of course, yeah. Some electrolytes can be quite challenging because of the very narrow biological variation in the patient, and as well as the clinical need for that particular analytes does not quite match up with the ability for current analyzer technology to deliver that level of performance. So, some analytes, yeah, of course, if you go on the Westguard website, you will see that some analytes, can only achieve 3 sigma or 4 sigma, and some analytes may be able to reach, 9 sigma, 10 sigma. So, there are different things. There are different technological limitations, but I think with proper management of calibration of reagents, as well as with instruments and training, we can help labs to at least reach the highest that they can given the current technological limitation.
Yes, I'll just add with this, strategize how to incorporate sigma in different level by level. So first they can incorporate based on CLSI, then they can go for the biological variation, minimum, desirable, optimum, and if they can take the clinician's opinion also about the clinician decision limit. Same example for HbA1c, we incorporated the cap, this thing total allowable error, cap decided total allowable error when we find difficulty with others. So thank you so much, Dr. Douglas, for this excellent presentation.